Hello, folks. Good afternoon. We are going to go ahead and get started and let folks just kind of trickle in. Um, so, good morning, good afternoon, depending on where you are. I'm Laura Brannon. I'm going to be moderating our webinar today. Could I get the next slide? Thanks. So about the National Partnership for Dental Therapy, if you're not familiar with NPDT, we are co-chaired by Community Catalyst, who I work for, the National Indian Health Board, and the National Coalition of Dentists for Health Equity. And we came together to try to increase the visibility of dental therapy and really be a gathering place for people from all different political backgrounds and from all different geographies who share the common goal of supporting dental therapy. Next slide. So while today's webinar is about a topic that is really applicable beyond just dental therapy, we are going to be talking specifically about dental therapy a bit. So realizing that some folks on may not have much background in that, we did want to give a little bit of context so everyone is able to follow the discussion. So if you've never heard the term dental therapist, these folks are not therapists for your teeth, but instead they are primary oral health care providers. So this is someone who could do an exam, they'll do oral health education, they can fill a cavity, they can remove a baby tooth with a lot of disease in it, and in some cases, they can even remove adult teeth. These are folks who work as a part of the existing dental team and under the supervision of a dentist. And they attend education programs, like the one we'll be talking about today, that are accredited by the same entity that accredits training programs for dentists and dental hygienists in the US. And those standards require that their training programs be a minimum of 3 academic years. I will put emphasis on that word academic because I think most of us remember from our time in school that usually means 2 semesters. So if a school wants to do something a little more innovative, like we're going to hear about later today, and use, that empty summer semester as well, you could actually condense those 3 academic years into 2 calendar years, which some schools do. Next slide. So as I mentioned, dental therapists are part of the dental team. They are not independent. They're working under the supervision of a dentist, and adding a dental therapist can make the whole team work more efficiently. So they work alongside dental hygienists and dental assistants. And all the different providers have a role on the team. Next slide. And one of the great things about dental therapists is while they can work in traditional dental clinics, they can also provide care in more settings. Most dental care is provided currently in dental clinics with hygienists and dental assistants sometimes being able to do preventive care in public settings like schools and nursing homes. One of the great things about dental therapy is that these providers are able to bring more kinds of care, actually restorative care like filling a cavity, into these settings, as well as they can work in, like a small town that's a little ways away from where a bigger dental clinic is. So it's a really great way of bringing care to people where they are, and therefore removing barriers for folks who need to get care. Next slide. Quick snapshot of dental therapy today in the United States. We have had dental therapists working in the US for 17 years. They're currently working in 5 states, and they're authorized in at least some settings in an additional 8 states. And there are about 200 dental therapists in the US. That number is increasing really exponentially as more education programs open. There are currently 5 education programs operating in the United States, with the most recent one opening in September, which is the program at Skagit Valley we're here to talk about today. Next slide. And just to give you a little geographic snapshot of where dental therapy is, your orange states here are going to have dental therapy authorized in at least some setting, and your blue states are going to be states where there's been recent legislation to authorize them. As we are talking about Washington State today, I want to highlight the fact that it is our only stripy state on this map, and that is because under current legislation in Washington, dental therapists are allowed to work within the tribal healthcare system. They're not allowed to work outside of the tribal healthcare system, which is not the case in most of these other orange states. I do know that there is an effort to expand that authorization, which John might talk a little bit about today for us. So next slide. All right, thank you. So now that we have that basic groundwork, I want to introduce our presenters for today. As I mentioned, I am Laura Brannon. I'm the project manager for dental therapy at Community Catalyst, and I'll be your moderator today. And we've got two really awesome presenters. We have Darren Greeno, who is the Executive Dean for Instruction and Workforce Education at Skagit Valley College in Washington State, and John Stevens, who is currently a consultant to the Swinomish Indian Tribal Community, but who I know spent many decades working for SWIN, recently retired, and upon retirement, I believe, was the CEO of the Dijawalik Wellness Center. So I am going to ask if we can take off the slides, and so I can get into conversation with my wonderful presenters. Thank you all. All right, so John, Darren, thank you guys so much for being here today. John, I'm going to start with you because I feel like when I want to sort of tell the story of creating this education program, to me, the story begins with the Swinomish tribal community. As you know, the Swinomish were the folks who really had this idea and were the ones who were really the original driver. So can you tell me a little bit about why was Swinomish interested in dental therapy and eventually in creating a dental therapy program? John, can you hear me? I'm afraid he might have frozen.
Sure, Laura, I hope that you can hear me okay.
There you go. Yep.
Uh-oh. Can you hear me okay now? Yes? Okay. My name is John Steve. That's my name. I should give you a proper Haida from the Haida Nakamshwan Lisninga Kiaga. And I was administrator for the tribal community for 42 years, overseeing all of the tribe's health programs, which included both medical and dental clinics. And on the medical side, we had for years supplemented our workforce with mid-level providers, nurse practitioners, PAs, et cetera. And the area of greatest need when I was asked by the tribal government was to improve oral health. We had significant oral health disparities. And when I started analyzing our service delivery model and the personnel that were staffing it, it became obvious to me that we were running a fairly inefficient system on the dental side because we did not have any mid-level providers on the dental clinic side. So in 2012, we did a procedure code analysis, and I don't know if you can bring up that slide, the procedure code analysis, please. I'm sorry, I'm not seeing it, but I'll go ahead.
It's showing up for me, John.
Looked at procedure 3 full years and plus this show. Okay. More than 50% of the procedures and services that were being made in the dental clinic Swinomish have been provided by dental therapy.
Hey, John, your connection is breaking up a little bit, so I'm just going to turn off your video, and hopefully that way we'll be able to hear you all.
Okay.
So please keep talking, and hopefully we'll be able to hear.
Okay. And the analysis that we did over those 3 years showed that half of what the dentists were doing could be done by a trained dental therapist using the same scope of practice as exists in Alaska. In addition, when I looked at our finite budget, it was determined that we could do half of those procedures at half the cost of a dentist. Therapists in Alaska being paid about half of the salary range that dentists are provided. So we determined that we could do a couple of things by pursuing a mid-level provider model. That is, increase efficiency by having mid-levels perform about 50 procedures that didn't require as much training as a dentist, and they could do it at half of the cost. In addition, that would free up the dentist to do the more complex procedures that they're trained to provide. So it was a win-win all the way around for us to start addressing what were significant oral health disparities. And that's how the journey began.
Thanks, John. And that, I think, to anyone who's familiar with sort of the broader healthcare system, that really makes sense, because in, I think, the medical system more broadly, we're used to seeing a lot of different categories of providers. I know, especially when I go to a doctor's office, I might see a physician, or I might see a nurse practitioner or a physician assistant. And, there are all kinds of additional sort of provider types that have entered the medical field in the past few decades, and there's been a lot of research showing that those people are able to, expand care for many people, particularly cost effectively. So it really makes sense that a similar sort of idea would work also in dentistry. And can we take down the slide, John, unless you wanted that? Nope.
No, that's fine.
Perfect. So, we've talked about why you wanted to be able to expand your workforce, but let me ask you the other piece that I know from having gotten to talk to you about this a lot of times is that being able to create this education program and then, be able to hire these providers wasn't just an opportunity for the Swinomish community to lower its cost of providing care and therefore provide more care. It was also an opportunity to change who was providing the care. Particularly, it was an opportunity to have people who were members of the Swinomish community become providers. So would you mind talking a little bit about, why to Swinomish was it important to have providers who were members of the community, and why do you think that sort of representative healthcare workforce matters?
Absolutely. I didn't really emphasize it in the opening, but Swinomish, much like most tribes in the United States, have been poorly served by an under-resourced Indian Health Service. And we had decades of deferred oral health needs in the community. And there had evolved, frankly, a culture of fear of going to the limited dental services that were available, because most people had zero preventative care. And the only time they went to the dentist was when they were in extreme pain and had teeth extracted. So over time, we had multiple generations that had poor experience with dental services, and we needed to address trust and fear as part of addressing oral health disparities. And one of the most important things that we felt we could do was to train tribal members, Native people, to provide a bulk of services in the clinic, people that they were familiar with, might be related to, that could relate to them culturally and had an affinity for, and could develop trust. So cultural competence became a real priority in moving forward to developing the dental health aid therapy program. And it was key to us to allow tribal members to see a pathway to good jobs in a shorter period of time, rather than 6, 7, 8 years that it would take to be trained as a dentist. So the Alaska model was the sweet spot for us, which we pursued and thoroughly advocated for over a number of years to train mid-levels in a much less less length of time, 2+ years to get people through an entire program and then be able to deliver services to their own community.
Thanks, John. And I think that story you tell about, a lack of trust and feeling like a lack of respect, a lot of sort of trauma is not, I think unique to the tribal community, because I know I work with communities across the US, and I feel like I hear this story frequently from people who are members of historically excluded groups. Is unfortunately we have a healthcare workforce and a dental care workforce in this country that frequently doesn't look like the communities they serve. And so I hear so often that, it's not, that this isn't just a tribal problem, that people absolutely want to be able to have a provider who is a part of their community. And whether that community is, a tribal community in Washington State or Alaska, or, a rural mining community in Minnesota, or if you live in South Los Angeles, that people want to be able to have that sort of trusting relationship. But as I think we're going to talk about with Darren a little later, frequently to become a healthcare provider in this country, it is a lot of years of education and hundreds of thousands of dollars that many people from particularly historically excluded communities are just not going to be able to access. They're not going to be able to afford. So I think that this program is so exciting because this was an opportunity to have more care going to community members while creating jobs for community members and rethinking what education should look like, to be able to create that pathway. And I think that's just a really exciting piece. So let me sort of start to bring in the piece about the education program. So, Darren, I'm going to go to you next, if you don't mind. And would you just mind telling us a little bit about the ayəbus, which I know is what the education program at Skagit Valley is called?
Yeah, I'm happy to. Maybe let me do 15, 20 seconds on Skagit Valley College just to seat the program within it. So Skagit Valley College we have 2 campuses, Mount Vernon, Washington. It's about an hour and a half north of Seattle, and in Oak Harbor on Whidbey Island. We serve about 7,000 students per year, and we've been here for almost 100 years. So we're 96 years old, second oldest community college in the state. We're a comprehensive community college, and in Washington State, we're authorized to offer bachelor's degrees as well. So we have bachelor's degrees, 2-year associate's degrees, and certificates. The ayəbus program, our dental therapy program, sits within our workforce education unit with about 20 other workforce programs. Think nursing, medical assistant, welding, diesel technician, on and on. And although the program is very unique, and I can go into some of the details about it, it very much fits within the college's mission to be able to serve students that have oftentimes traditionally been underserved in order to increase their educational attainment and their social mobility. The dental therapy program, as John alluded to, has been a lot of years in the making and would not have been possible without the partnerships that we have, particularly the Swinomish tribe. John has been a very big part of that, as have others. So I want to begin by acknowledging that and our other tribal partners within the state and within the region. So the program, I guess I'll speak in broad brushstrokes first, Laura, just to make sure I'm getting to your question, and then if there's more detailed questions, we can go there. But as has been mentioned, the program takes place over 2.5-ish calendar years, but it packs 3 academic years into that time period. So Washington State is on a quarter system. Typically, a academic year for a typical student is fall, winter, spring quarters. Students can take a summer quarter. But it's for our dental therapy students, 4 quarters a year. for 2 years plus a 9th quarter. They are here from 8 to 5 every day, Monday through Friday. So it is very immersive, it's very intense, and it's cohorted. So the students begin together, they take all of their courses together, and we work as hard as we can to make sure that they all graduate together. The course, the program is accredited by CODA, which I imagine we'll dive into a bit. It is approved by the Northwest Commission on Colleges and Universities. So it is not only a professional technical training program where students are learning skills, but they are attaining an associate's degree. So they are taking general education courses that include math, communications, English, etc. Those courses are contextualized to fit within a larger framework of the health sciences and oftentimes specifically dental therapy, so that the coursework is contextualized to improve student learning and to make sure that every minute, every credit that we have with our students is valuable to them and valuable to their learning.
Thank you, Darren. Something that we have heard from you talking about with this program, it is offered quite differently than I think probably most people's experiences in college, where you talk about the fact that it is an 8 a.m. to 5 p.m. Monday through Friday education program, basically year round for about 2.5 years. And that's a really different sort of model. So, Darren and John both, I'd love to hear from you. Why was this sort of different model exciting to you or interesting to you, as opposed to offering, just a traditional sort of academic calendar? And, why did you think that was going to be the best course for your students? And John, if you
jump in, but I can go for it, and then John, you just fill in the gaps. From our perspective, this is our philosophy within building the program is that it's a community-based program. And so the decisions that we made to build the program in the way that we did was based on multiple partners that we have. And one of the partners that I didn't mention are the folks in Alaska with the program hosted at Lushootseed College. And they had built a program and we modeled ours after it. So one reason right off the bat is there's a successful model. Let's look at it to use. And there's a lot of evidence that students, so even if you're in a traditional program, there's a lot of evidence that shows that cohorted programs contribute to student success. So having students not enter whichever quarter they want, but enter together and then move through a program together is very beneficial to their learning and the peer-to-peer relationships that can exist. There's also a rhythm that students can get into that can be easy to get out of if you're not part of a tightly cohorted program, moving from course to course in a very prescripted way. I guess another bucket is there's a lot to learn, and to pack the amount of content that we need to pack into the program to maintain accreditation, to make sure that our students are trained to be highly proficient dental therapists as they exit. It's going to be a high credit program. And if you stretch those credits across calendar year after calendar year after calendar year, then there's a cost and a burden to the student, right? So during this time, students are at college full time. They've oftentimes moved their families or moved away from their families. So to ask them to make an even additional sacrifice to fit into the college's model, which would maybe be a program stretched over 3 calendar years, it wasn't student-centered. So I know John alluded to a few other elements, and I'll hand it over to you, John, but at least from Skagit's perspective, that's why we were willing to try to think outside of the box in terms of how we deliver the program.
Well, of course, Darren provided a very appropriate academic summary. Let me approach it from an additional perspective, and that is from an Indigenous perspective. The cohort structure is much more culturally consonant, tribal values, and it allowed multiple people to go through the program together and to be mutually emphasize that for most folks that we anticipated entering the program, a 3-year commitment from a familial and cost standpoint would be anywhere from daunting to impossible. So the more it was compressed, and Darren covered the positive aspects of that compression, it was better in a higher retention rate.
Thanks, John. You broke up a little bit, but I think, I definitely heard you talking about how it's better from an Indigenous perspective to be in that cohort so that your students can be mutual support for each other. And also really the importance of thinking about what does it mean for a student's life when they are giving up, when they're moving to a place for a program, what does it mean for their family? Frequently, if they have kids, if they're moving their kids along as well. And I think that's something that I find really interesting is that I've heard you both talking a lot about this, and I'll be honest, I don't hear a lot about this in higher ed broadly, is I don't hear a lot about concepts of like opportunity cost. The fact that a longer education program, it can mean more tuition, but it can also mean opportunity cost. If you're spending 3 or 4 years as opposed to 2 years, that's an additional couple of years that you're not getting into your profession and starting to make money. So I think that's really interesting. And Darren, I know I've heard you talk about this a little bit today and in the past about really you guys' sort of focus on being that pathway for non-traditional students or low-income students, but would you mind talking a little bit about that? Because I'll be honest, from my perspective, that's not always something we hear from everyone in a higher ed, a real sensitivity to and a lot of attention to how do we actually make this a program that's helping people, advance economically for themselves and for their families.
Sure, and I think the response holds true for the ayəbus or for other workforce programs. Skagit Valley College, like other community colleges, is an open door institution. So our median age is 24, but in the workforce area, it's around 30. Many students are coming to us after having a career. Maybe they want to change careers. More than half of our students have children. So when you take the diversity just by those 2 points, let alone socioeconomic status, previous education, the diversity of our students is what makes the college special. And in my opinion, is what makes the community college sector special. And part of our mission is not only to equip students with the skills they need to graduate, but to look beyond graduation and to make sure that they have a pathway that after achieving an academic credential, they're able to move into the workforce, into a position that's going to be rewarding, both from a day-to-day aspect, but also from a financial aspect. So there's a whole other conversation or maybe webinar there, because that's not always easy, right? Industry changes. The college needs to change in order to make sure that we are providing programs that provide students a pathway into high wage, high demand jobs. But dental therapy is a profession that it's relatively easy to make the argument as an institution to create that pathway, because just from a cost benefit standpoint, the wages are there for students to move into a high paying position. And, we can speak to some of the things that maybe are a little less tangible, but maybe less tangible to speak to, but they're very tangible in action, that the reward that students get to return to their communities in a position of, say, a dental therapist and have that positive impact is, I think, oftentimes beyond the financial reward that students can get. So yeah, I hope that answers your question, Laura. I'm happy to dive in deeper if it didn't.
No, that was great. Thank you. So let me also ask you, Darren, and then John, I'm going to ask you a follow-up question on the same point. You mentioned the program is an associate's degree program, and I know Skagit Valley offers both bachelor's and associate's degree programs. I think that no one would argue that there has been a national trend towards what I would kind of called degree creep or degree inflation. For a lot of professions, the standard degree keeps going up, and sometimes that's in response to scope change, but sometimes it's not, which also means the amount of education expected for students and the amount of time and debt keeps going up and up. But you guys, I know, following the example of Alaska, which for anyone who doesn't know, Alaska had the first dental therapy program in the United States, decided to make it an associate's degree. Can you talk a little bit about, how you feel about sort of sticking with an associate's degree sort of in this broader context of degree creep?
You want me to go first on that one, Derek?
Yeah, or John, if you're comfortable with it as well. I will be honest, I come to this having
Sure,
said, as somebody who works on dental therapy, is that sometimes people will say to me, well, some of them only have an associate's degree. Is that good enough? And to me, the answer is, well, if you graduate from an accredited program, yeah. But so John, let me ask you that question. Like, how do you feel about the concept of an associate's degree and this question of, is an associate's degree good enough?
Simple answer is yes. The students that were being graduated from Lushootseed in the Alaska Dental Health Aid Therapy Program, there was research done on the quality of work that they were doing, and it was done by independent researchers out of the University of Washington. And the dirty little secret is that the students that were graduating from the 2-year program had as high quality, if not higher, than dentists for the same procedures. Now, therapists can only do 50 to 55 eligible procedures, where dentists can do a few hundred. So that the therapists that were being produced actually had more practice on the procedures that they were performing on their patients than the dentists did in dental school. And when the independent research verified that the quality was equal to or better than a dentist for those procedures, it was a really simple philosophical advocacy position to come to it for Swinomish. And that was, if we can produce high quality students producing high quality work in a shorter period of time, that's what we should do, because it will be good for the students, little lesser disruption in their lives, and we would get a workforce from the community to be able to deploy them quicker in our own clinic.
Thanks, John. And Darren, if you have anything to follow up on that point.
Yeah, I think that's a great answer that John provided. And I'd say from the college's perspective, it's around outcomes, and what are the outcomes that we are seeking to have our students achieve. And as John said, the amount of hours that, and therefore credits, we have built into the program provides students a significant amount of time to be able to achieve those outcomes, and we could still do it within the framework of an associate's degree. So really, I think the question is less around, you can have an associate's degree that's 90 credits, you can have one that's significantly higher, right? So I think folks think associate's degree, 2-year degree, and they're not necessarily familiar with, say, all of the laboratory time, all the clinical time that's going into, say, a program, well, like nursing or dental therapy. And the associate's degree structure absolutely provides that space for students to achieve those outcomes. So for us, it helped that we had a model in Alaska to look at and say, this works. But I think I would like to think that even if there weren't that model, we would have had an open mind to look at it in that way.
Thank you both. And I think, Darren, you mentioned earlier accreditation, and I think that's a really good, I keep coming back to that point because, Skagit Valley College is the second dental therapy program in the country to get accreditation. For anyone who doesn't know the background, there are 5 education programs in the country, but several of them were created prior to the existence of these accreditation standards. So they're having to go back and go through. Skagit Valley was the first new program to go through the process, and so getting accredited from the start. So I think the fact that there are currently 2 education programs in the country that are both that have been accredited, and they're both associate's degrees, I think also is a really strong sign that sometimes what degree it is doesn't, like, people have a lot of stereotypes, I think, sometimes about what it means to have an associate's degree or the kind of people who get associate's degrees, because I think there's a lot of classism as it applies to education in this country. And I think you also have a really good point that your students are doing a huge number of contact hours and education hours in this 3 academic year program that you have put into an associate's degree framework in about 2.5 calendar years. So I'm going to change tack a tiny bit. And I know one of the other sort of unique things about this program is that you actually split it across 2 sites. And if I'm correct, the first year of education is done on the Skagit Valley campus, while the second year, which is when the students are working on patients, is actually in the Swinomish Dental Clinic. And I think this is a really sort of exciting way that you guys found a way to make sure that you have patients, that you're lowering your cost of providing this education because you were able to use an existing clinic and not have to make a brand new one. So, John or Darren, whichever of you feels like the answer, can you talk a little bit about kind of how you came to that idea of being able to, like, even share space and how you made that work?
Go ahead, Darren, because you were the internal academic disruptor.
That might be true, but again, I think the model that we have would not have been possible without disruptors on both sides. So typically a program is going to be housed, I think, fully within a college campus. What we talked about and decided is that the benefit of having students in a clinic environment, not only for their clinicals, but for their lectures, et cetera, happening within a fully functioning clinic space would be the most beneficial for students. So that's the aspirational element. The other part is it's very expensive to build these spaces. So we should collaborate to utilize resources and leverage them as efficiently as we can. So you're right, Laura, and I'll give folks a description if they didn't catch it or want more information, but the program is structured that all first year courses, all first year students spend most of their time at Skagit Valley College in Mount Vernon in a brand new lab that we have built. So the 8 to 5 Monday through Friday schedule takes place for first years in Mount Vernon. And then the second years have their entire program housed at the Swinomish Dental Clinic. And although we're fairly close, we're 20 minutes apart, we try to have the students, I think students are there almost once a week right now, even in their first year, not working on patients, but just becoming familiar with the facility. And that type of engagement from a workforce education perspective is the gold standard. And so you could say that about dental therapy or any other professional technical program. So I think we were very excited to be able to build a program within that structure, knowing that it would benefit students, knowing that it would be an efficient use of resources. And it's trying to find the best words for this. It really is a marker of the partnership that we have with the Swinomish tribe, right? This program has been built collaboratively. It is operated collaboratively.
Thanks.
And the only thing that I would add to Darren's excellent summary is that the second year being on reservation in a tribally operated clinic under direct supervision of dentists at Swinomish, and being able to immerse the students in an actual tribal clinic operation and interact with native patients. We saw great value in assuring that the students had that kind of experience and exposure prior to moving forward with their licensure and being placed in a variety of tribal clinics.
Thanks, John and Darren. And I think this is a really exciting sort of idea. And I know it exists in some other kinds of health workforce education, but I think that this is an exciting idea of the way that colleges can partner with clinics, whether it is a tribal clinic like Swinomish or community health centers or other sorts of clinics, to sort of make better use of existing space, and also be making sure that like students are actually really seeing a lot of patients and realizing that they're seeing a broader swath of patients than they might otherwise. So I think that's really exciting, and one of those sort of lessons I want to sort of pull out of this, because I think this to me is one of the really exciting innovations that you guys have done, and that I hope is sort of copied by other folks. I mean, you know, I really hope that a lot of what you guys have done is copied by other folks, because I think you've got such an exciting model. So let me move on to a little bit about sort of the process for making this program. And, you know, Darren, I'm going to start with you, and I'm going to put you on the spot because I've heard you talk about this before and I loved you talking about it. I've heard you talk about the fact that creating this program really sort of required you guys to move away from some of the traditional ways of academia, and you've talked about those specifically, but can you talk about, you know, from a perspective as a dean in a college, how did you really sort of think this through and get support within your college for sort of moving away and co-creating this program with Swinomish, which I realize is not the traditional way of creating an education program?
Yeah, that's a great question. I hope to answer it well. There's so many parts to it. Maybe I'll start with, you know, any other educators that are in attendance know there's a lot of baggage in higher ed. We've been around for a long time. Each institution has their way of doing things, and it oftentimes is a good way of doing things. But, you know, maybe as often there are ways that we can improve that we may not take advantage of because there's a structure that we have to work within, and then sometimes changing that structure can be difficult. So this, I think the relationship that was forged over the years prior to even building the dental therapy program was very important, right? The trust that needed to be in place between the college and Swinomish was established, you know, not only within the dental therapy program build, but previously we're neighbors. We have a 3-county district in which the Swinomish tribe is a part of. So we're looking to serve our community. But one, the very structure of what we have seen as a successful dental therapy program is just invariably going to look different. Like we talked about earlier, if you tried to fit the model into a traditional community college program model, it's not going to be as beneficial for students or their families. The other aspect, I think, is what John mentioned, that there are very specific needs of the dental therapy students that we have that we want to be respectful of, and that cultural humility that we needed to bring not only included how we treat individuals, but how we're going to go about building the program. And so what that meant to us was that we are going to step out of our normal positions or how we would normally view things and start from scratch and say, what would benefit our community, what would benefit our community partners, and what would benefit our students. And I'm very fortunate to have leadership at the college that were willing to let us work in that space that was not hindered by all the baggage. And the reality is, it's not that far out of the box what we're doing. It just meant that we needed to create different practices in order to make a program that doesn't look like the rest of our programs work. And, you know, there are a few advantages that I think we had that at the same time you could see as disadvantages. As an example, I think there could have been advantages if Skagit Valley College had a dental hygiene program, because there would have been an infrastructure there to build from. At the same time, that would have provided the very structure that we might have needed to move away from. And so it really is going to be, I think the answer would vary from college to college, in terms of the infrastructure that's built and what you're looking to build. But I think the key component for us, which I've already mentioned, but I'll bring it up one more time, was a sense of humility that we're a learning organization, and we have a lot to learn around dental therapy as a practice and around what an educational program can look like. And our partners in this process, which include many more than I've been able to speak to, helped us in that learning. And I think the end result, which is still evolving, is the dental therapy program.
Thanks, Darren. I think it's listening to you talk about this, how you approached it, with like openness and humility. And I love you talking about being a learning organization. I think that is an amazing attitude to bring to higher ed, and one is not necessarily always reflected across all of higher ed. I know a lot of other amazing educators like you. But I also know that in a lot of higher ed, there's kind of a bias towards this is the way things are done. So I think it's really exciting to see you talking about how you guys innovated, but also saying this isn't that crazy. Like, it's not that far out. It's just sometimes even small changes can seem big. So I've got a few questions from some attendees. And then I've got a couple of final questions for you both. So let me ask you, Darren, if you can answer a question. Someone had a question about your faculty, though I think specifically about qualifications, and I guess about like how you guys recruited faculty.
Yeah, so we have 2 full-time faculty that are dentists. There are requirements through CODA that we have DDSs on board. The recruitment process was national. It's I'd say unique in the sense that there are communities that are not familiar with dental therapy as a practice. So we had to make sure that we modified our job description and our recruitment process to be able to accommodate that. It was a fairly intensive process because we wanted to make sure that anyone that we were bringing into that full-time faculty role not only understood dental therapy as a practice, but understood the philosophy in which we're building the program. So it was, maybe don't need to go into the details, but a little more expansive than a search committee interview onto the president, and that's it, right? There were multiple stops and stakeholders that were a part of the process.
Thanks. And someone else had a question earlier. I just want to clarify. They had asked about prerequisites. So am I correct? Students coming into the program, you're expected to be a high school graduate and to meet certain other standards, but you don't have to have any previous college experience. Is that correct?
That is correct. If there's any attendees in Washington State, you'd be familiar with this. If not, you might not. But Washington really pioneered a process or a pedagogical model called IBEST, Integrated Basic Education Skills Training. And it's the idea that you have co-instruction that takes place within a classroom with a disciplinary expert and then a subject matter expert from a field that may be related. So within an English course, that course within the dental therapy program is actually contextualized and co-taught with a dental therapy instructor and an English instructor. And it's a way for us to be able to serve students and help them get through transferable 100-level English courses, and regardless of loading up a list of prerequisites to make sure that they get to that course. So it's a tried and true model across the state, but this is the first time it's been done in dental therapy.
Thanks, Darren. John, my next question is for you. Got a question about how CODA accreditation has sort of affected, I guess, the perception of dental therapy. And I'm going to ask my own piece of that question as well, which is particularly considering that this program is CODA accredited, which is the national standard for all dental education in the US. Would you feel comfortable mentioning, the fact that dental therapists in Washington are currently restricted to only working in tribal communities? Do you think that is a reasonable restriction considering they're graduating from a CODA accredited program?
Well, you're asking me to engage and provide my perspective of the political dynamics of dental therapy. I see the hook, but I'll be narrow in my response. And that is that the CODA accreditation is the gold standard. It assures that students, as Darren said, the college is interested in outcomes, and the tribal communities are interested in quality outcomes for their students to provide quality care. And the fact that we can identify that the program is itself accredited by the commission is a positive thing, and it improves the perception of those who think that their therapists are somehow lesser trained to do the things that they do on patients, or they provide lesser quality. Neither of those things are true. Swinomish spent 5 years advocating for a statewide dental therapy bill. We, along with other partners in that political process, were unsuccessful in a statewide dental therapist authorization. We switched tacks after 5 years under direction of Swinomish leadership and moved to a tribal sovereignty approach, which basically said that under tribal sovereignty, we had the right to design a program and develop providers that met the needs of the tribal community. And we developed a regulatory and licensing framework at Swinomish to do that. And that allowed us to bring the first therapist into the lower 48 who was an Alaska native who had been trained in Alaska. And we used the presence of that therapist in the dental clinic to springboard the balance of the political process to authorize dental therapists in tribal settings across the state. There's a complex set of dynamics there related to opposition from the Dental Association, who consistently had opposed a statewide authorization. But after 7 years, the Dental Association finally came to a position of what they characterized as neutrality to the state authorizing therapists on tribal reservations and tribal clinics. So there's a few different webinars in that answer, but being able to say that the students meet the gold standard from CODA is a positive thing overall.
Thanks, John. And Darren, I know there was a question about class size, which I think you answered in the chat, but I just wanted to make sure everyone heard it. There was a question, class size. You said your class size has a room for up to 12, and you guys are hoping to educate folks from beyond just Washington. And am I correct? You actually have a student from outside of Washington in your first cohort.
We do. We have a student from Michigan. I think what we're trying to do is serve our regional community immediately, but we are obviously, we know we're part of a larger endeavor. So as there are students that are interested from other states, then we would be happy to have them here as well. The dental lab right now has space for 12. We have built the space to expand up to 16. So in the future, if that expansion is appropriate, we will be doing it.
Got it. Thank you. And I got a couple quick questions. One for John. There was a question about dental hygiene for patients in the Swinomish Dental Clinic. About you have hygienists on employee, right? Employed?
Yes.
All right. So yep. So I know the Swinomish team. You have dentists, dental assistants, dental hygienists, and dental therapists all working together.
Correct.
Awesome. And then I also had a question here about how you're working with dentists in Washington. And John, you just referenced the fact that, I know the Dental Association, at least in the state of Washington, has been traditionally opposed to dental therapy. But I know dentists, Darren, you just mentioned earlier, you've got several faculty who are dentists. And John, you've got, multiple dentists at your clinic who have been working with dental therapists for years. Is that right?
That's correct.
Awesome. So I think, would it be fair to say that while the state association remains opposed, many individual dentists are supportive?
I think that's a fair statement. The Dental Association adopted a neutral position with regard to therapists on tribal lands, but the association continues to exhibit opposition to a broadening of the authorization to the balance of the state. Now, we have viewpoints on that. Simply put, many of the patients, tribal reservations, for instance, there's a high percentage who are eligible for Medicaid, but only about 10% of private practices in the entire region are accepting new Medicaid patients. So there's a real access problem, in particular for tribal Medicaid recipients off the reservation, but it's a problem for Medicaid patients in general. And at some point, that access question, I think, will become an even greater question for a lot of policymakers. And at some point, the reality of limited access to oral health services is something that needs to be addressed. And the introduction of mid-level therapists, we think, helps provide a pathway to increasing access for lots of people.
Thanks, John. All right, so we have very little time left, but I'm going to ask you each a quick question, or it's a complicated question, but I'm going to ask you to give a quick answer. Darren, I'll start with you. If you had one piece of advice to give other educators who are looking to build a program, in partnership with a community like this, what would that be?
It might sound a bit repetitive, but I think it's approach the process with a new lens. That there could be possible outcomes that you didn't think were there. And that kept happening to us in good ways and sometimes challenging ways. But I think being open-minded and eager to partner and eager to find a solution really did help Skagit Valley College, I think, fulfill what we set out to do with our partners.
Thanks, Darren. And John, a very similar question. If you had advice for other community leaders or health leaders who were looking to partner with a college to build an education program, what piece of advice would that be?
Simply put, oral health disparities, in our view, are a public health crisis. Community colleges can fill a significant role in workforce development to produce providers to address that public health crisis. And be persistent. Don't give up. It took us 12 years to get where we're at today. If we can do it, others can do it also.
Thanks, John. And I think that's a great note to close on. I love that. If you guys can do this, others can do it as well. So I want to thank both of our amazing presenters for being here today and thank our wonderful audience. We will be sending out a recording of this webinar and slides. I did see a question in the chat about whether this would be released in podcast form. And oh, you flatter me. No, I do not. We do not have a plan for a podcast, but we will be releasing this as a recording. So thank you all so much for being here today, and take care and happy holidays, everyone.